Welcome to the Equine Vet Connect podcast. I'm your host, Dan Carter. I'm a veterinarian and a farrier. The goal of this podcast is to educate horse people, break things down, bust myths, and keep it real. Speaking of breaking things down, here's my legal disclaimer to keep my attorney and insurance company happy. While I am a vet, I may not be your vet. Contact them before trying anything you hear on this podcast. Remember, just because you watched it on YouTube or heard it on a podcast does not mean you can do it. Please use common sense. Welcome back to the Equine Vet Connect podcast here at Countryside Equine Hospital. We're back in the old studio today. Got Dr. Tori Martin with me, one of our vets here. We got a lot of questions about this, and I thought it'd be really good to do a follow-up episode. We did one on exercise-induced pulmonary hemorrhage and the role Lasix plays in that. The other word, the short word for that's a bleeder.
Yeah.
And so we had some questions, so we're going to go back into this. We hear about this a lot in the racing world, and we hear about it a lot in the barrel horse world. But I think one thing I want to say is this can actually happen to any horse.
Yeah. I mean, we mentioned in the Furosemide podcast about a horse out in pasture that was running around. It was hot out. Horse, I believe, was like mid-20s.
Yeah,
so later in life. And yeah, it really can happen in a lot of different circumstances, not just racing.
No, absolutely. And that's one thing. And I think it's important. Let's say you're not into racing, you're not into barrel horses, but I think this is good to listen to just in general, because like I said, we have one that's happened to in the pasture.
Mm-hmm.
And this can happen too when we're bringing horses back into work, if we push them beyond what they're ready to handle. Because we're going to do one on legging horses up and getting horses fit. My podcast we're kind of getting that one put together, but we always think about muscles. We always think about legs, but we never think about lungs. We never think about the upper airway, but all that stuff plays a role too. So I think it's good to talk about in everything. So, quick overview. Let's talk a little bit about, all right. So we got exercise-induced pulmonary hemorrhage.
Mm-hmm.
You're going to hear us call those bleeders, because really exercise-induced pulmonary hemorrhage is a lot to say the entire time. So we're going to go with bleeders today.
Yeah. And you'll see it termed EIPH if you're reading about stuff, that they'll shorten it to its acronym. But bleeders is going to be kind of your layman type term that we use for this condition.
And I know, I feel like I got friends that are in the military, and they got an acronym for everything. And I feel like vet med's about the same. Like we'll make up an acronym. But yeah, we abbreviated a lot of different ones, EIPH, bleeders. So we're gonna stick with those terms today. So let's do a quick overview with a bleeder.
Yeah.
So what we got there?
So what we have to think about with bleeders and kind of what's happening, and we touched on this in our Furosemide podcast, but we'll get into it a little more here, is that when we're at exercise, again, it's exercise induced, so there has to be an exercise component to call it this. At exercise, we have a lot of physiologic changes happening in the body because we have increased tissue demand for oxygen, for blood flow. So we're getting, systemic increase in blood pressure.
Yeah, blood pressure goes way up in these guys exercising.
And a lot of that is cardiac output, but also in horses, when we're doing high levels of exercise, they have a big reserve in their spleen that's then contracting to produce more red blood cells, and by produce into the bloodstream, because it's basically a reservoir. And so, looking at a high level output, I actually found some information. We're getting like 10 times the cardiac output. We're getting twice the amount of viscosity in our blood because of that increase of red blood cells. And we're actually increasing the left atrial pressure in the heart by about 10 times as well. Now, that's in extreme conditions.
Yeah, so, when you really think about it, we're making the heart pump harder. It's pushing more blood out just from it. And then also the spleen's dumping in those red cells. So we're actually increasing blood volume as well.
Exactly.
And so those two things can skyrocket blood pressure.
And their heart rates will go up significantly.
Oh, yeah. I've seen them in the 200-300s. I mean, and a normal resting rate is, 20, 30 beats per minute in most horses. And these guys will, like when they start exercising, it'll push into the 200-300s.
Yeah. So we're talking almost tenfold in our heart rate as well.
Yeah. So rate increases, how well the heart pumps increases. and then we increase the blood volume, our blood pressure it's through the roof.
And then we also talked about the benefit of, physiologically in exercise. We have a lot of vasoconstriction that happens as well.
Mm-hmm.
So we're getting more volume and we're getting it in a smaller pipe.
Yeah. Perfect recipe for really high blood pressure.
Exactly.
And then on the respiratory side, you're breathing heavier.
Mm-hmm.
So your pulmonary pressure is going up. Basically, the pressure inside the lungs from the air is
Mm-hmm.
also increasing.
Right.
And that's why when we talk about bringing horses back to work, it's important, because if anybody's ever done exercise, like if you've ever been a runner, if you've ever been a bicyclist, done these heavy, intense exercise classes, when you first start, your respiratory rate is way higher. Your heart rate is way higher when you first start.
Mm-hmm.
Over time, the body adapts.
Right.
But at first, it's a lot higher. So that's why horses that are returning to exercise, you need to watch out for this as well.
Yeah, I think we think about that in ourselves more than we do in our creatures.
Right. And I think a lot of it, horses are kind of natural athletes. So we don't think about it as much in them, but it's important to remember when you're legging your horses up, this could happen as well if you push them too hard, too fast.
Mm-hmm.
So all those things happen, and we get rupture of the alveolus. I always think about, like, I almost brought
the capillaries in the alveolus.
Capillaries in the alveolus. I often think about grapes.
Mm-hmm.
If you think about a cluster of grapes, that's what the alveolus looks like. Really thin cell walls, one layer thick.
Mm-hmm.
I mean, we're not talking like one cell layer.
Mm-hmm.
And you can't see the cell with the naked eye. You've got to have a microscope to see it.
Right.
And that's all that stands between that capillary where the blood is and the lungs. Mm-hmm. There's not a whole lot there.
Right.
So absolutely, like, perfect storm for this to happen. When we're looking at these clinical signs, they can present in a lot of different ways. These horses will cough.
Mm-hmm.
Some of them actually get epistaxis.
Right.
Fancy word for nosebleed. They'll get some epistaxis, and you'll actually see blood coming out of the nose.
Yeah, and what's interesting about that, though, that we have to remember is that when we actually look at, like, who's been diagnosed as a bleeder and then the percentage at which actually has a true nosebleed, the percentage is pretty small.
Right.
In comparison to the actual prevalence of this condition.
Right.
So we can even just see changes in performance where they're not performing as well as they normally would. You could be going to look in an airway after exercise for other reasons and happen to see a little bit of blood in the trachea. Mm-hmm. But you may not even be able to visualize it. It may be a matter of going down into those lungs, getting cells, and finding out that we've got some blood cells down deeper in our lung field.
Right. So the best way I've seen to get this truly diagnosed, you've got to have a scope. Mm-hmm. If you're going just off a nosebleed, because you've got these same capillaries,
you're gonna miss them
up in the nasal passages, and those can have the same issue.
Right.
You really need that scope about 30 minutes after. But yeah, we went pretty in depth in that in the podcast on bleeders. Mm-hmm. And the other thing is, we talked a lot about Lasix then. Yeah. Talked a lot about Lasix. So if you're wondering about Lasix, go see that podcast. It's going to go way more into depth there. The question that came in is, once you have a bleeder, now what? Yeah. And I think that's an important topic. Like, if this is truly diagnosed, either through an endoscopy and you see the blood in the trachea, or through a BAL or transtracheal wash. We talked about there's different cells we can see in there called hemosiderophages that give us an idea of that. What to do once this happens? Right. One of the things I often think about is you've now got blood in the lungs, great growth media for bacteria. You've got body temperature, good old 98 degrees Fahrenheit.
Oh, absolutely.
In a sense, you in not a sterile environment. Lungs are not sterile. Mm-mm. So this produces a great place for bacteria to grow.
Absolutely. Secondary pneumonias because of these bleeding episodes is kind of our biggest concern in the immediate aftercare for someone, for a horse that's bled.
Yep. Secondary pneumonia is a big deal. So when we start looking at these factors as far as what to do, if you have a horse that bleeds, first and foremost, time is your friend. You got to have time off.
Rest is probably the keystone of recovery.
If you do not let these lungs heal,
Mm-hmm.
you're going to continue to have this problem. And I think that's the part that nobody wants to do.
Right.
Is the time off. You kind of hate it because now we're starting over again.
And depending on the severity of the bleeds, we have a lot of different grades of these. Depending on that severity, that rest may look a lot different for one horse compared to another.
Right. So I'm kind of a minimum 2 to 3 weeks.
Mm-hmm.
I've had some that get to that 4 to 6 mark.
Yep.
If it was a really bad episode, we're looking 4 to 6.
And then if we do get a secondary pneumonia, which we try to prevent by doing our different treatment options, that could turn into longer.
Right.
So we just have to keep that in mind, that it's not my horse bled, put him in a stall for 2 weeks, they'll be fine. Mm-hmm. It's a lot more complex than that.
I think it goes back to like a common, like I always think about, like every time we do a podcast and we talk about a subject, it goes back to a couple things: early and accurate diagnosis, early and aggressive treatment.
Yep.
And doing like that is like the hallmark right there. Just try to stay ahead of it. So when we've got this, and we know we've got a confirmed bleeder, we've got to have that time off. To me, the hard part is like knowing exactly how much, because there's not a good way to check and like, oh, our lungs are healed, we can now go back to work. It's a little bit of a guess.
Yeah.
But it's as educated as we can get. And the next thing we've talked about is, we're talking about the secondary pneumonia.
Yeah.
That's a killer.
Absolutely.
This is where we're going to come up with antibiotic regimens. And I think it varies a lot. Like, I'm an Exceed guy.
Yeah, I think in majority, it's usually we're reaching for an Exceed or a TMS in most cases, and looking into, preparing for this podcast, looking into what everyone's doing and different reports and things. Those are the most common that I saw.
Yeah, I think Exceed's great because it's basically a long-acting ceftiofur. Great on gram-positives, works great on streps, high affinity for the lungs. Yeah, that's something we don't talk about much. I think we did cover this a little bit in our antibiotic episode, but when you're picking an antibiotic, it's not just about what bacteria will it kill, but it's also like different antibiotics have different affinities for different structures.
Right.
And for whatever reason, ceftiofur likes the lungs.
It does.
So that's usually the one I grab. What's your experience?
In the cases that I've had, that's been what I've reached for. But I've also worked with doctors that have reached for your TMS, your Equisol, your Uniprem, something along those lines.
The sulfa line, yeah, a lot of people reach for the sulfa. And that's, I've used it quite a bit as well, because a lot of times these horses are traveling somewhere. They may not have access to Exceed, but we can get them on those sulfas.
Well, and the thing with Exceed, like we have the long-acting component, which is nice, but we also want to dose that horse again. It's not just the first dose that's important. It's getting that second dose a couple days later. And to your point, sometimes getting them on something oral that the client can give, you would think that less doses and not putting it in the client's hands to be responsible for would be less compliant. But in some cases, you're more likely to get a horse to go through a course of an oral treatment that they can give than you are going to be able to get that horse back in to see you sometimes. Yeah,
and I'll send a lot of those home with that second dose as well. And, the other thing to look at, too, is Exceed, the ceftiofur, great on gram positives, very minimal gram negative spectrum there. And TMS, even though it's been around for a long time, it's pretty broad spectrum.
It is.
It gets both. So it's another great choice. So I think it's a personal experience. I think it is what you want to reach for. I don't think there's a right or wrong there.
Right.
But, some of these do progress to secondary infections, and we do get these mild pneumonias. And that can also set us up for more damage to the lungs, which increases our risk of bleeding again.
Right.
So, when we're dealing with that, one of the things we're going to reach for, if when we recheck these horses, they're just not performing well, we may reach for that transtracheal wash or a BAL, bronchoalveolar lavage, to see, is there more going on in here?
Right.
And it's not uncommon to find these secondary low-grade respiratory infections.
Right.
A trach wash, pretty easy procedure to perform. Your vet can do it. We do it through an endoscope, very minimally invasive. Same thing with the BAL, really minimally invasive. It sounds terrifying, both of these, but They're really not.
I think the VAL sounds a little more frightening to people than the transtrach wash.
Yeah, the BAL, you're going a little deeper into the lungs.
You're using
but
a little bit higher volume.
Yeah, you do, but I can tell you, I've done a lot of these, and
You're not going to drown the horse.
they're not going to drown the horse. Like, we think it's a lot, but it's
really not.
So, but getting that, and the important part there is to find out what's going on with that infection.
Mm-hmm.
Getting the cytologies, and then also getting the culture and sensitivity. Because, like I said, we picked an antibiotic, we took a swag at it,
Mm-hmm.
but we don't know. Maybe there's a different bug in there that's not sensitive to it, and then we got to change up our regimen.
Right.
So I think it's important that if you feel like your horse isn't recovering the way it should after a bleeding episode, get your veterinarian involved.
Right.
They should have been involved to begin with, but bring that up to your veterinarian. Don't just say, "Oh, well, he's just struggling to get back to work." Be like, "No, it's been a couple weeks, and we're really struggling still."
Yeah.
We need to look a little deeper here. So I think that's important.
Absolutely. And the follow-up, and we say this about a lot of things that we see, but like the follow-up in a bleeding case is probably, I would put it on a higher scale of importance than a lot of things that we see, just because of the kind of nuances of we can't really see fully what's going on in the lungs. And it might just be as simple and complex as, oh, well, they're just not quite where they need to be. And that could be more significant than we realize if we don't actually go look at them. Right.
Because you can I've had these horses that have had poor performance for a long time. And when you do these BALs or you do these transtracheal washes, you find these low-grade respiratory infections. You start tracing this back, and you find out, we had this episode about a year ago, and we haven't been right since.
Yeah.
This is why. The body's somewhat keeping that infection in check, but it's still dealing with a low-grade infection. The lungs are pretty cool. I mean, they can withstand a lot.
Right.
But they do get to a point they just can't.
Something we also need to consider, because if we haven't already made it sound like it's complex enough, let's add a little bit to the mix, is what happens after bleeding. If they've had a bleeding episode or they have recurrent bleeding episodes, we're then at that point, we're worried about starting to get some fibrosis in these lungs.
Absolutely.
So from a treatment standpoint, it's not just, hey, we need to get this infection under control to help improve performance, create a healthier horse, reduce risk of it happening again, which if they've bled before, they're always at risk for bleeding again. We need to be on top of it to a level that we're preventing fibrosis to the best of our ability. So this is where we kind of get into the kind of other side of the treatment in anti-inflammatory.
Let's talk a little bit about that fibrosis.
Yeah.
So fibrosis is the easiest way I think of it is scar tissue, the lung scar.
Yes.
When anything scars, it loses elasticity.
Right.
Lungs, I mean, the volume they can expand is incredible. And being able to breathe, it's all about those lungs being able to expand.
Right.
If they lose that elasticity, inhalation's more difficult, but really what gets you is exhalation. Because they expand, but they're not contracting back down when that neck, because there's no muscle that really that pushes on the lungs. You have a diaphragm that creates a negative pressure in the chest, so the lungs get bigger. But then when their diaphragm relaxes, it's up to the lungs to expel that air. And when you get in that fibrotic situation, your respiratory performance, it goes down markedly. And one of the things we know, like you just said, the more episodes you have of this, the greater your risk of fibrosis in those lungs and decreased elasticity.
Right.
So absolutely, you're 100%. Like it's more than just the infection.
Absolutely. So when we consider that, we have to consider, the other mainstays of treatment and therapies and anti-inflammatory, considering whether that's just a straight anti-inflammatory or if we're using steroids in an anti-inflammatory capacity.
That's something to remember too. Steroids have two doses. You get immunosuppressive. You've also got anti-inflammatory. You can use those.
Well, and we can also nebulize
absolutely
steroids, which is more direct to the source.
Mhm.
So this is a place where a nebulized steroid, if you have your bacteria under control, can
Mhm.
be a really great part of your treatment plan. And
Mhm.
we also consider bronchodilators in some cases that are more severe.
You know, that's one that comes up a lot is the bronchodilators. The main one we use is either oral clenbuterol or venipullin or inhaled albuterol.
Albuterol. Yeah.
And I'm a big fan of opening those airways up because we need to clear this stuff out because you're not, all the blood's not just leaving. You're going to have some that stays behind. If we can open those airways up, we can get more of that out.
Right.
I think about it like, it's not the same thing, but if you have a cold, you take guaifenesin. Guaifenisin's an expectorant. It helps get things out of the lungs. And so I think it's, that's important to clear this debris from the lungs. We don't use guaifenesin, obviously, in horses, but we do use, I like venipullin. I'm a big fan of using a bronchodilator.
Yeah, absolutely.
So I know some people say it could be contraindicated because you are increasing resting blood pressure. So there is some concern you could have further bleeding, but I guess I'm not one of those.
Well, my thought on that is, well, we're resting the horse.
Right.
So if we kind of go back a little bit to this increased pressure, because I found some numbers on this, we're increasing the arterial pressure in the pulmonary system from like a normal 25 to like 95 at high exercise.
Right.
So I don't think our clenbuterol is going to get us up in the 90s.
No.
Just so for me, that's kind of risk reward. I think there's more reward than risk. I would agree with you on that.
Yeah, I agree 100%. I think the risk is
But if
minimal.
you also if we say, hey, rest your horse 2-3 weeks, put them on this ventipulmin, and you decide to go work them while they're on it, then in that case, you may be having a compounding effect. That's why the rest is super important.
Absolutely. Got to rest. And I think, one of the cool things that we've got are these nebulizers now. And I think, managing a whole host of different airway issues, we can put the medication right where we need it.
Absolutely.
And so using those nebulizers, because when we're like, let's talk steroids. We're using such a low dose of fluticasone, we're not worried about immunosuppression.
Right.
The anti-inflammatory effects way outweigh the risk of immunosuppression. And fluticasone, that's my steroid of choice because it can actually penetrate deep into those lung tissues. Dexamethasone, there's a couple studies that are out there. I think we're still lacking a slam dunk, but the concern is, does inhaled dexamethasone actually get deep enough into the lungs?
Yeah, I was going to ask your thoughts on that because there is a lot of kind of controversy.
There's contradicting studies, but I think a lot of it has to do with there's not a great way to determine that.
Exactly.
But we know fluticasone gets there.
Right.
And we're talking about tiny molecules, and we know it gets deep into the lungs. And so I think I like inhaled fluticasone over dexamethasone. I think it's also important if you're going to use a steroid, you got to have that bronchodilator on board because we got to get it there.
Right.
So when you're setting up these regimens, it's important talking to your vet because a lot of times, like, I'm going to have some type of a bronchodilator in there as well, either mixed in with my fluticasone, or I'm going to lead with a bronchodilator and then add my steroid. But yeah, absolutely, steroids are fantastic for preventing that fibrosis.
So one thing to kind of pick your brain on from your experience, immediately after a bleeding episode, reaching for something like furosemide.
I haven't, at that point, I think the horse is already out of the barn.
Yeah.
That's my thought. It's already out of the barn. I want to keep them almost overhydrated because we do know if we want to get things out of the lungs, moisture is our friend. In fact, I've even nebulized some of these horses with saline.
Yeah.
To keep things moist, to get that, to try to clear some of that debris from the lung fields.
Yeah. I would agree with that. I think that the argument for using it in that case, like immediately after, which I don't think we mentioned this aspect of furosemide in that podcast, but it can cause some relaxation of the smooth muscle in the venous system that's in the pulmonary system. But to your point, we're not at work anymore. We're not at these high pressures anymore. So I would agree with that.
Yeah, I think the horse is out the barn. I don't think that's
Yeah.
not what I'm reaching for.
Exactly.
One thing that is kind of interesting that's a newer treatment that's coming out is using some of these biologics to help heal the lungs.
Mm-hmm.
Alpha 2M is one.
Yep.
They're actually using some different PRP compounds
Mm-hmm.
and nebulizing these. And I think it's going to be pretty interesting to see where this goes.
Absolutely.
If you think about it, it makes a lot of sense because, we've been using biologics, these like PRPs or alpha 2s,
Mm-hmm.
not so much alpha 2s, more PRPs. But we've been using this to heal tendon and ligament injuries for probably a decade or more.
Right.
More than a decade, probably 2 decades. And we started using them on wounds.
Mm-hmm.
And we've seen amazing benefits of stimulating the body to heal. And so now there's a lot of work saying, all right, well, if this is working to heal wounds and decrease fibrosis, we're healing wounds and decreasing fibrosis
Right.
in these structures, can we use this in the lungs?
Mm-hmm.
And there's some new studies coming out. We're a little short on studies, but there's a couple studies that are showing pretty big improvement with the use of these biologics nebulized. So I think it's something else that we need to consider.
Absolutely.
I think timing's important on it. I don't think when you, like the day you bleed, I don't think that's the time to do it.
Yeah, no, probably not at that point.
I think it's, you kind of got to think about this in stages. You got the initial trauma.
Mm-hmm.
We got to give that a few days and get over that hump.
Mm-hmm.
And then, because I guess I think a lot about tendons and ligaments too, is we used to think the faster we got the biologics in, the better it was. And what we've learned is the body, if you put a biologic in too soon, it's going to get used somewhat as an anti-inflammatory, but the body's not at the stage where it's ready to start healing tissue yet.
Well, and my little thought behind that, which I haven't dug into the studies about, timing and that nature, but in the lungs, for example, since that's kind of the focus of our talk today, if I've already bled into a region, then those bits that we're taking from the blood are already kind of there doing their job. Like we're kind of adding what's already there. And, we may not think of a lesion in a tendon to be this big bleeding lesion.
But it is,
but
actually.
But it does.
Yeah.
And we don't always remember that there is that component to it. So I feel like when we try to jump on these things early with a biologic, we're basically giving the body what it's already got.
Well, that's been my thought is, like on tendons and ligaments, I want to be 2 or 3 weeks out before I start introducing the biologic. Because like I said, you do get bleeding into them. You essentially have PRP there.
Your plasma's there.
It's there.
It may not be super concentrated down, but it's there.
It's there. And so I like to so that's kind of been my thought on how I've been delivering some of these biologics is, and we're actually using these more than just bleeders. If you've got horses with some of the asthma cases, some of the inflammatory airway diseases, we're starting to use it in those as well. So I think it has a lot of benefits, and to me it makes a lot of sense. If you're trying to get something to heal and decrease fibrosis, if I'm dealing with a tendon or ligament injury, or if I'm dealing with skin, I'm grabbing a biologic. So it makes sense to me that if we're trying to do the same thing in the lungs,
it's just an injury on the inside.
Yeah, it's an injury on the inside. And so it's changing how we look at it.
Absolutely.
So that is something that we're starting to do more and more. Like I said, we've only got a handful of studies out there right now, but most of them seem to be pretty positive.
Well, and it's newer for us to use them in this way. And in order for us to know the best ways to use them, the best timing to use them, and all of that, we've got to start using it more.
Well, and that's one of the things we saw using biologics on tendon and ligament injuries. When I first started using biologics, this was like new. I mean, it was like crazy thought, right? And I've watched the progression of the use of biologics and us learn more and more and get better and better. I started out like the sooner I can get it in there, the better. Some of these papers started coming out and being like, hey, there's an opportune time to get this in, and you can put it in too soon.
Well, and I bet if you look back at the cases you did early versus the cases you started to push it out, I bet you saw different results.
It'd be interesting to go back and review some of those. I'm kind of curious. But yeah, so I think we're dealing with the lungs. My approach right now is I'm going to treat it with the knowledge I know about a tendon. Because if I'm working on collagen structures, which is what we're talking about in the lungs, I'm going to say, okay, collagen is collagen. I'm going to take the knowledge that we've learned from tendon and ligaments, and I'm going to put that into how I treat the lungs. So we're going to get over that initial acute phase of injury.
Right.
I want to be 2 to 3 weeks down. We've had the rest. We've had the medications on board. We're pretty confident we don't have a secondary pneumonia. And then I'm going to start reaching for these biologics. So a lot of great options out there. I know the alpha 2M, they're pushing it from the anti-inflammatory aspect, and then also there are some growth factors in there.
Right.
And so I think there's a lot of promise in this area that we may be able to actually, we've always said for years we can't reverse the effects of bleeding. I don't know if we're going to reverse it, but if we can markedly slow it down,
right,
that's big win.
Absolutely. Well, I mean, if you stop it in its tracks, then you're not going to reach the levels of fibrosis and secondary concerns that we've been seeing. Because it used to be, I found a paper, I want to say it was like 80s, 90s, but you couldn't, if it bled like from its nose, then it was a bleeder, but we really weren't using endoscopy initially. We didn't have it.
No.
So at the point that you're actually noticing these are high grades, not to say one that has a severe bleed has been doing it for years. We don't know that, but those are the only times we were catching them before. So of course those horses probably at that point were not being intervened on in lower level type cases.
Well, and that's kind of where my thought, like, this isn't just a racehorse issue. This isn't just a barrel horse issue.
Right.
I really wonder if we push horses to their max, because we know we get these subclinical bleeders in that population that aren't showing the blood from the nose. But if we're pushing them too hard, too early, could we be having the same effect?
Right.
So I think it's, in my mind, I think it goes beyond just racehorses and beyond just
maximal exertion.
Right. Because I've even wondered too, like, we never talk about it in the 3-day event world. Most of those horses are really well conditioned, but when we're first legging those horses up, could that have an effect on, are they having these mild episodes?
Right.
It really makes me wonder, because if you really think about it, you've got a lot of the same, you've got a lot of the same setup there. You got high exertion, longer period of time, but you still got high exertion. And this could definitely occur there as well.
Right.
So
it's probably really underreported. Like, it probably, as you like to say, sees us more than we see it.
I've often wondered that.
I bet you it does.
Yeah, it's something I've, I always talk about. It's my 3 a.m. thoughts. Like, this job's almost a disease to me, because I wake up at 3 o'clock in the morning and something pops into my head, and I'm over there staring at the ceiling fan spinning around in circles. I'm like, well, why couldn't it happen there? Are we missing this? And so that's one of my 3 a.m. thoughts that's really had me questioning, like, some of this poor performance and some of these eventers, like the upper level eventers. Could this actually be happening? Because they may be completely in shape. I mean, racehorses are fit. They still have these issues.
Yeah.
So could this be happening there?
Well, and that may be something that we need to consider more in our performance evaluations, that if we have a horse that's not performing at the level that, we feel that it should, maybe we find something and we need some injections or whatever, but maybe those are horses that we need to trach wash or BAL just to see.
Right. It does raise the question. So, because used to, the number 2 cause of poor performance was the airway. That changed hands and became stomach ulcers, became black gastric ulcers. But I think the reason that changed hands is we became more aware and we started looking. And now I'm wondering, like, okay, well, what if we actually started looking in some of these other horses and considering this?
Yeah, we do a really good job of doctors as creating an increased prevalence by hunting things.
Yes. But and the fact is, it's there.
Oh yeah, no, it's not saying we're falsely elevating it, but we definitely can elevate the prevalence by looking for something specific.
What's that old saying they taught you in vet school? You miss way more not looking than not knowing.
Yes. And
I think that's something that kind of popped in my head a few weeks ago, and I was like, I need to I need to be more vigilant about this.
Well, and it happens in life. You see this car, this truck that you haven't seen before, and after you see it one time, you're like, I see it everywhere now.
Yeah, I thought the same thing with those cyber trucks.
Yeah.
I was like, oh, there's a cyber truck. That's really cool. And now I see them everywhere. It's like, and the same thing happened. I remember when my dad said he was a pilot, and he said, you pass airports all the time, but you're not trained to recognize them. And sure enough, when I became a pilot, I realized driving down the road how many airports I had been passing for years.
Every single day, and you just didn't even know it was there because you weren't looking for it.
Yeah, it wasn't looking for it. It wasn't on mine. So, yeah, I think we've got to look at it in other disciplines as well, not just racehorses or something that's working at speed. I think it is more prevalent. So I think it's important when we talk about that, and we're talking a little bit about what to do afterwards. The next question is, when we bring these horses back into work, they've had the time off, we've treated them, we bring them back into work. I think it's important to look at how long they've been off, and then how long we should take to get them back into work.
That's a good point.
I've heard some people say if a horse has got, a week off, you need to take 2 weeks getting it back. If it's had 2 weeks, you almost double. I've heard that. And I do think there's some truth to that. I do think there is some truth to properly conditioning these horses when you come back, and starting slow.
Yeah, it has to be gradual. However you do it, it has to be a gradual build. You can't say, all right, let's jog for 2 or 3 days and then go full force.
I think paying attention to your respiratory rate. If you get out there and you're doing trot work and your horse is blowing, hey, we don't need to increase.
Right.
If we start doing canter work or we start loping, if they're struggling to breathe and that respiratory rate's high, let's back down a little bit. Let's get back fit. Let's get back conditioned.
Well, and then that could also beg are we doing something during this recovery time or rehab time, like a bronchodilator or something of it? Because I think that there's mixed kind of views on that too. Because in one hand, if we do bronchodilate, we may be making it easier on them to breathe better and to have more oxygen exchange. But also, are we doing that to get them more conditioned faster when really we need to be taking longer, as opposed to,
I really think if you do this right, you should be off meds.
That's my thought.
Yeah, you need to be off meds before we start working.
Yeah.
And yes, this takes time, but there's the old saying, you can do it right or you can do it twice. It doesn't do you any good if you hurry back to work only to have this happen again.
Yep.
And need more time off. Like, it just doesn't make sense. So I think that's important. And also understanding, we are bringing these horses back, doing exercises that increase that fitness.
Yeah.
Slowly working through that and really focusing on your horse and paying attention to it.
Right.
Like, what is that respiratory rate? Do they seem a little sluggish? They seem to be struggling. Really pay attention to those things as you go through, and I think that's a better driver of how long it should take, more than a calendar.
Yeah, and we have to be really attuned to that, because unlike, someone training a person or rehabbing a person, they're not going to tell us, hey, dude, I can't breathe.
Right.
I'm going to say that if you start pushing me too hard, but they can't tell us that. So we really do need to be acutely attuned to what's going on and looking at the full picture.
And knowing your horse too, because the equine athletes are no different than human athletes. If they love their job, they're going to do it. Hurt, not hurt, doesn't matter.
Yep.
They're going to push through. And so you've got to be the one that says, hey, you're not ready for this.
Yeah.
And I think making that decision, like, only once you're back up to fit and up to, let's say, pre-bleeding status, should we look at going back to work.
Yeah.
Because if we bleed again, we're starting all over. So doing this correctly, I think, is the way to go.
Now, I know this question is probably going to come up, and we've only got a couple minutes left. I have not dug into this side of things yet, so if you and your experience have, or we can touch on this another time. I know people are going to ask if there's supplements or other things that they can do to either prevent or to help in recovery. I tend to steer away, generally speaking. But if you and your experience, I know that's going to come up. I guarantee you that comes on this podcast.
Yeah, supplements. My biggest problem with supplements is
Lack of regulation.
lack of regulation, lack of real data, lack of true.
Right.
And it's difficult to do this, right?
Right.
Because if you say I gave this and my horse didn't bleed, if I gave this and my horse didn't get lame, well, there's a lot more factors than just you gave this.
Right. Absolutely.
So I tell everyone they probably don't hurt. I doubt they hurt.
But we don't know that they're actually helping.
But then I don't know if they can help.
Yeah.
And I'm one like, if I tell somebody something works, or if I tell somebody to do something, I want to know 100% that I've got something backing me up that says, hey, this is it. Because I feel like I'm staking my name and reputation.
Well, and the things that we use, we have the data supporting that they work.
Right.
But we also know why they work.
Right.
And I think sometimes with the supplements, like, again, they may not do harm, but we don't really know how they're contributing to.
Yeah, and I think that's, and one of them we actually know a little bit about spirulina.
Yeah, that one's talked about a lot.
That one, spirulina, is talked about a lot. So there's actually been quite a bit of work on it. Using it a lot for inflammatory airway disease. I do think it has some, I think there's some benefit there. Basically, because there's been some not superstar great studies, but some pretty decent studies looking at spirulina on some of the inflammatory airway cases. And so I think there is some benefit to that product.
Yeah.
How much and to what degree, I really don't know.
Right.
But I do think there is some benefit there. And I think, I feel like I get accused of bashing supplements a lot. and I'm not. I don't know.
Yeah. I feel like there's a lot of unanswered questions.
And I always get hesitant when a company does its own research.
Yeah.
That's the beauty of the peer review process, where you have a blinded study and you've got control groups. And that's why there's so much effort put into studies, is to really understand if it works.
Eliminate bias to the best of our ability.
Absolutely. You can never 100% eliminate it.
No.
But you can definitely minimize it.
Right.
And so I think that's important when we talk about the supplement world.
For sure.
So, I mean, it's no different than when you heard us talking about the regenerative stuff. Like, this is new. We got a few studies showing promise.
Yes.
We're not saying this 100% works.
Yeah, no.
But the data is telling us, and I always say the data and the nerds are telling us that, hey, this has got some benefit here.
Right.
And it makes sense.
Right.
We look at, this started just by extrapolating from, we extrapolated from what we've done in tendons and ligaments and wound care. And we said, wait a minute, this is an internal wound. Why wouldn't it work?
Right.
So there's some factual data behind it.
Absolutely.
And so that makes it a little easier to say, hey, that's where we need to go.
Of course.
So, well, I hope that answers the questions out there. Because like I said, we were getting a lot after that last episode. So I'm hoping this answers some of those questions.
I feel like it might also create some
It's
more.
probably going to create more. And I think the hard part about this topic, and the reason there is so many questions, is we don't have all the answers yet.
Right.
We didn't even get into, some people talk about using aminocaproic acid.
Yeah.
And that's in the acute phase. It should help stabilize clots and get them to stop bleeding. But again, that's acute phase. You got to have it.
I think that's kind of where it starts and ends.
Yes. Like to me, that's you better have it with you. And this is not an easy thing. Like, you can't just carry this one with you and give it. You need a veterinarian on site to pull this off. So, like I said, first couple hours, that's where I see the benefit with aminocaproic acid.
Yeah.
So, all right. Well, hopefully that answers a lot of the questions people had. Thank y'all for sending in questions. We love questions. We've actually, I was looking through some of the questions we've got, and I think we're going to do a round table of Q&A.
Oh, okay.
So I want to, we'll be looking for that podcast. We're going to just sit down, and it may not necessarily be a topic, but it's a whole host of questions we've had asked. So
I like that
I
idea.
think it'd be a pretty cool podcast. Some short answers to think questions people have. So
get us on our toes a little bit.
Yeah. Well, thank you for being here this morning, April. Thanks for recording this and editing everything. I didn't say Casey because Casey's on vacation, so April is doing the editing this week. So But thanks to everybody here. Thanks for y'all, the listeners out there. We really appreciate it. And if y'all got any questions, give us a call. Thanks.